everybody. Um, my name is Maggie. I'm a Vice Chair of the BCS Digital Clinical Risk Management SIG, Registered Nurse and Clinical Safety Officer. Welcome to everybody for the first in a series of webinars on understanding large language models. I am a CSO. I work very much in the field of 0160, so I'm about the deployment and use of health IT systems. And I know very little or relatively little about large language models, but I have been asking my colleagues to make certain that the information on this webinar is particularly accessible for those of us who know little about it. In this session, we will provide an overview of large language models, what they are, how they're developed, and how they function. We will explore applications of large language models in healthcare and touch on safety and regulation. The next webinar will focus on clinical risks associated with using LLMs in healthcare, and we'll discuss strategies to mitigate those risks. There will be time for questions at the end of the session, but there's so many people on the call, we probably won't take voice calls. We would love you to put your comments and questions in the chat. We will endeavour to collate and respond to as many of them as possible today, and we will use all of them to shape the content of subsequent webinars. And as I just said, the session will be recorded and posted on the BCS public website. Speaking today, we have Paul Llewellyn, who is a member of the Digital Clinical Safety Specialist Interest Group, and Accenture CCIO and CSO, also a registered nurse. Ahmed Ulusow, data scientist at Accenture with a focus on data and analytics for healthcare. His previous experiences within data and analytics across health and public services, and he has an academic background in biomedical engineering and data science. And Gabriel Desouza, who is a strategy consultant in Accenture's UK health practice. He's been working in the health data and AI space for the last 3 years. Prior to this, he worked for about 10 years with his local provider and ambulance trust in Essex. And now I'm handing over to Gabriel, who will start the presentation.
Very much, Maggie. Nice to be here, everybody. Happy Thursday. So first, I think before we dive into, large language models and exactly what they are, what would be good is if we just kick off with, what the conditions are that have really opened the door for us to explore LLMs and look at the opportunity for using them within healthcare. So we first need to look at the challenges that are currently facing the health service. Now, the challenges here on this slide, everyone will recognise the NHS and healthcare systems globally are under immense pressure. There's a pressing need to cut costs, address workforce shortages, and significantly increase productivity to manage the rising demand. And these problems together can't be solved by, simply adding more staff. There isn't a surplus of clinicians available anywhere in the world to draw from, and you may not have the budget to hire them. And as a result, healthcare systems are turning to technology, particularly artificial intelligence, as a key part of the solution. And the NHS already recognises the role AI can play. It's highlighted in the long-term plan of 2023, the workforce plan of 2024. There's the NHS AI Lab initiative that's been running for a number of years. And there's recent publications from NHS England, particularly around ambient scribing. And there's an acute government focus, as you can see on the quotes from this slide from the Prime Minister a few months ago. And at the core of many applications of AI in health are large language models. So why are LLMs so prevalent within health? So firstly, healthcare is inherently human. Nearly everyone at some point in their life interacts with a health service. This means any technology that's used within this space must be able to handle, the wide variation in human language and understand it in broad, general, flexible ways. And large language models are uniquely capable of doing this. Secondly, they don't just understand the natural language, they're also able to generate responses that feel natural, conversational, human. In healthcare, obviously, this is especially important. Communication needs to be patient-centered, it needs to have accurate context, and it needs to be empathetic. And LLMs can replicate this kind of tone and nuance. So anyone on the call who might have used, ChatGPT or Gemini, you'll see how the responses you get from your questions go far beyond those kind of generic replies. They feel like a real person has written them. And last but not least, large language models are really well suited to health data, and we'll explore what we mean by that in these next few slides. So for any kind of AI to work, it needs data, and the majority of data in healthcare, we estimate around 80%, is what we call unstructured data, whilst the remaining 20% is structured. So what's the difference? So with structured data, this is organized, labeled, and is quite easy for computers to process. This 20% of data is what we've been able to use really well so far. Think of it like data in a spreadsheet or data in designated fields of your EPR. It's in clearly defined rows and columns with rules around the content. And that includes things like, patient demographics, maybe their vital signs, lab results, or diagnosis codes. And because it's so well organized, structured data is easy to search, sort, and analyze, and it's very good at telling us what is happening. On the other hand, you'll have unstructured data, which is everything that doesn't really fit neatly into those fields, and it's hard to analyze using traditional methods on a computer. So it's messy, but it's really rich in detail. And you'll see from the examples here, clinician notes, discharge letters, radiology images, scans, voice recordings, even PDFs and emails would count as unstructured data. So for example, this very small case note on the left, albeit a couple of lines, that captures clinical reasoning and context and a bit of nuance in it. And that would require advanced tools to analyze from a computer perspective. So even though it's harder to work with, it holds enormous potential. And the power of a large language model is that it can process this unstructured data, derive context, and generate an output from it. So I'll hand you over to Ahmed now to talk about what an LLM is.
Perfect. So we've looked at why there's this new technology that could potentially be applied to healthcare, is useful, but we haven't gone to the point where we've looked at where it can be applied. I think before we get to that point, it's important to take a bit of a step back and try and understand what LLMs are, allow ourselves to have an idea of the language around it, and to be able to speak to some of these key themes. We won't have time to go into all of the areas in specific detail. The idea here is to touch on some of the key themes and give ourselves the background and language to be able to speak about the topic with a little bit more confidence. So large language models are just very big language models. So if we go on to the next slide, that means the question that we should be asking ourselves is, what is a language model? Language models are mathematical approaches to human language, so they help us to do things like understand and generate and predict human language. And the thing is, they've been around for a while, and they've been able to support us in tasks like translation. So you would have come across Google Translate. Google Translate is powered by a language model. Text generation. So if you take the example that you are writing a text and on the top of your keyboard there's a word that's there that's predicting the next word that you could potentially be using. All of these ideas are powered by language models. So the thing is, they're not new, and there's been a rich history of language modeling. So how has language modeling changed over time? If we go on to the next slide. Language modeling is developed from a world where we use statistical and rules-based approaches in the past. And then there were certain graduations that were of key significance and importance to get us to the world of LLMs. We'll go into them in a bit more detail in the following slides, but they were things like neural networks, recurrent neural networks, and the transformer. But that then led to the world that we're in right now, the world of LLMs. I think LLMs became more and more sort of well known in the mainstream after the release of ChatGPT. ChatGPT was sort of an explosion into the mainstream for LLMs. For those of you that haven't interacted with ChatGPT or used ChatGPT before, I think I'd really recommend you just go on the website, It's super intuitive, and it helps give a flavor of what LLMs are capable of doing. But in order to understand how we got to this point, we'll have a deeper look at some of these three key themes: the neural network, the recurrent neural network, and the transformer. So to get to the point of LLMs, researchers tried to mimic the most powerful computer that there is. The most powerful computer is the one in your head, it's your brain. And what we do with neural networks is we try and replicate some of that activity. The neural network introduced complex computation to the world of language modeling. But the problem with the neural network was that it wasn't able to process context very well. So we were able to do this complex computation, but then that complex computation wasn't supported by context, and that's quite important in language modeling. So researchers thought again, and they introduced the world of recurrent neural networks. And what recurrent neural networks were neural networks with memory incorporated. And what that memory allowed for was for the same or similar activity of the neural network, but just with contextual understanding, context of what happened previously. The problem with the recurrent neural networks were that because you had to wait for everything in the past to have happened first, the processing was quite slow. So researchers thought again, and that's when the world of the transformer sort of came about. And what the transformer did was it brought a new architecture for processing information, and that allowed for a rich contextual understanding and fast processing. So with the neural network, we were able to process super fast, but we didn't have the sort of rich contextual understanding. With the recurrent neural network, we weren't able to process very fast, but we did have context. But the transformer brought about fast processing and contextual understanding. And this means that we can train models built on this architecture with more data than we could ever train before. All I've just said right now, though, is potentially quite confusing. It's just lots of words. So how do we try and use analogies potentially to try and help us understand this in a little bit more detail, something that's a little bit more intuitive? If we take the example for a neural network that a clinician enters a consultation room, they've got a complex case, they come in, and this clinician has never seen this patient before. There's no awareness of what's happened before. There's no relationship that's existed before this. And all the clinician sees when they walk in is a one-sentence sticky note of the patient's history on a board, and the clinician has to make a decision. In that case, the clinician is very well versed in medicine. They're trained in medicine. They understand medicine quite well, and they might make a good sort of prediction of or decision of what to do next. But that decision would be more powerful if they had contextual understanding of what happened previously with the patient. So for a recurrent neural network, let's assume the analogy that a clinician has walked into a consultation room and they sit down and they're listening to the patient and they're hearing one word at a time. And whilst they're listening to the patient, they're transcribing as they go. The doctor tries to remember what was said previously, but then by the time the patient gets to some of the important information, they might have forgotten how it all began. And especially if the patient's speaking for a very long period of time, it's quite hard to remember what happened previously, and there's just so much going on. There's just so much to keep in your recent memory that although the decision might be better than the decision that was made previously, it's going to take a longer time. And it's not as good as it potentially could be just because there's some forgetting that goes on. And that was one of the challenges with the recurrent neural network. The memory wasn't a memory that existed for over a long sort of piece of documentation. So then the analogy that exists for the transformer is if the clinician walks into a consultation room and what they see is a whiteboard in front of them, and the whiteboard has the entire patient history laid out. The doctor then decides on the course of action with all of the patient's information available, the history, and all of it is easily referenceable. So they might have forgotten something that was important, but they can just look across and gather that information again is totally re-referenceable. And what that does is it allows for them to make faster decisions with all of that rich context of what had actually gone on with the patient. And that, therefore, might be a better sort of decision that's made than the decisions that were made with the previous analogies. So we've tried to describe what the transformer is, how the transformer works, but this transformer, how do we go from just data in the transformer to the foundational LLM or the world of LLMs? What some of these big companies did was they took as much data as they could get their hands on, information from as many different sources as possible, and they trained these transformer architectures on this data. And what that then led to was the foundational LLM. If we go on to the next slide, foundational LLMs are a bit like a Swiss Army knife. They're trained on a broad range of data, and they can be adapted to a wide range of downstream tasks. So we've picked three foundational LLMs to sort of talk about. It's not an exhaustive list, but these three are picked so that we can touch on some other themes later on. If you've come across ChatGPT before, ChatGPT is powered by an LLM family of models called the GPT series. So when you're on the website for ChatGPT, you can actually pick the model. And that is produced by a company called OpenAI. Google, who were actually involved alongside the University of Toronto, they were involved in producing the research that first led to the transformer. They have a notable implementation called Gemini, so that's their sort of competitor for ChatGPT. And that's powered by Gemini, but they've also got a range of other models like BERT and others. And then another company that's produced foundational LLMs is Meta. So Meta is the company behind Facebook. They're the company that owns WhatsApp. And they have a model series called the Llama series, and they've released things like Llama 2 and Llama 3. And the reason that we pick these three to talk about is so that they can help us to understand a theme or an area that's quite important for security, safety, which is the open source and closed source debate. So open source models are those that are publicly available, so you can view their source code, anyone can download it, anyone can modify it, and then you can sort of share it. But then not all foundational models are open source. So different companies take different approaches to sort of the open source versus closed source debate. ChatGPT and the GPT series that's powering it isn't open source. The company Google, they have some models that are open source and some models that are closed source, but Meta takes a totally open source approach. And the reason that this area is important is because open source gives you things like the ability to customize the models, download them, modify them for your use cases. But then there's also a challenge around using them in terms of how complex they are to use. Closed source models, on the other hand, are potentially costly, but then they tend to have inbuilt security because these companies have been thinking about security, and they also have the support mechanisms as well if you're stuck. So there's a lower barrier to entry from a technical implementation perspective. You don't have to be as technical in order to use some of the closed source models. This open source and closed source debate can also help us get to the world of domain-specific models as well. So if we move on to the next slide, we spoke about foundational LLMs being a bit like a Swiss Army knife. The Swiss Army knife is good for a broad range of tasks, but you wouldn't take a Swiss Army knife into a operating room. You'd want to take a surgical scalpel. So how do you go from Swiss Army knife to surgical scalpel? There's layers of complexity of how you tailor models to be more robust in their performance in the medical domain. So there's something that we can all do, and it's the lowest complexity activity. We can all prompt engineer. So prompt engineering is where you interact with the model on a language level. So in your inputs that you're inputting into the model, you will structure them to guide the model's behavior, but you're not actually changing any of the underlying fundamentals within the model. And that's something that we can all do whenever if you're using Copilot at work, or you're using ChatGPT, or you're using Gemini or Claude, or a range of these other foundational LLMs. You can prompt engineer to make sure that the outputs that you get are sort of guided to the behavior that you want it to take. But there's a layer of complexity that's lower down that we might want to then take if we want to totally tailor to the medical domain. And when we enter prompt tuning, that's the sort of level that we enter the sort of coding realm. And just at a high level, all of these models, what they do is we give them words, they turn the words into numbers, those numbers then get processed, and then those numbers then get turned into words again. So what we're doing with prompt tuning is we're training the model so that it can add some numbers as prefixes to the original input, and that then makes sure that the output is more tailored to the medical domain. That is not as computationally difficult as the next thing, which is fine-tuning, which is to totally retrain a model using a curated medical or clinical data set. So if we want to think about how we go from that Swiss Army knife to the surgical scalpel, we'd actually want to work back up through the funnel. And where we start within this funnel sort of depends on the constraints within our organization. In order to totally fine-tune a model, you need access to lots and lots of computational resources, loads of computers and processors. So you might be able to start at the fine-tuning level, but you probably wouldn't. The prompt tuning level is something that we could potentially do, and then you work up towards the prompt engineering level. So let's take, for example, the examples that we'll see on the next slide, which are fine-tuned, and then some are prompt-tuned, and then whenever someone's interacting with them, they'll be prompt engineered. This is a list of medical-specific LLMs, and it talks to some of their strengths. I'm not going to sort of read through each of them. They're available for you to see. But what I will touch on this slide is that this is a science-based community. And what that means is whenever these models come out, we're constantly evaluating and measuring how well they perform against each other. So we're using things like benchmarks to see how well these models perform within certain scenarios. This helps us understand how well they work in these instances, but that also means it's not as easy to just say that there's the best medical LLM out there. It's important to understand, and it's important for all of us to have some of the language that we've touched on previously to be able to understand where these models are working well and where they work better than others, so that we can then look within our own constraints and look at the use cases and problems that we're dealing with to identify which models we should be using for these scenarios. So we'd previously touched on why LLMs would be helpful in the medical domain, because the majority of the data is sort of tailored to this world of LLMs. We've tried to do a sort of quick tour on some of the key themes within LLMs, on their history and how we got to them, some of the notable implementations, and how we go from that Swiss Army knife to the medical or surgical scalpel. Now let's look at the use cases that these medical LLMs are used within. Gabriel.
Thanks, Ahmed. So I think when it comes to large language models in healthcare, the landscape we see is evolving incredibly quickly. What we're seeing is a growing range of use cases. And as you can see from this slide, these are just a few of them, and they span the full spectrum of healthcare services. And And this is by no means an exhaustive list. Over on the left, we can start with how they are helping to optimize the back office. So mainly administrative tasks, essential for keeping the system running. LLMs can help here in a number of ways, chiefly in co-pilot situations. For example, if you work for the NHS at the moment and you may have Microsoft 365, you might already be using the co-pilot feature to do things like, summarize documents, generate meeting notes, create content, and so on. And this is all powered by some proprietary Microsoft models and OpenAI's as well. Moving one along to the particularly exciting area of how LLMs can help, support clinicians in their day-to-day work. Obviously, the standout here is how they underpin ambient voice technology, which has gained loads of momentum recently, especially with NHS England's, endorsement and the guidance they've published around that. Moving along to the middle with kind of preventative and population health, we see the use of LLMs for doing things like forecasting, planning interventions, and identifying risk patterns, helping us to be more proactive in our care. When it comes to kind of patient experience as well, these can help in a number of ways. Of course, there's a kind of very widely recognised use case of chatbots, something that we've seen, especially in other industries like telecoms or utilities. If you've got a query with your mobile phone provider or your energy supplier, your first port of call is probably going to be a chatbot. And these tools can help provide 24/7 support, guide patients through maybe simple queries, and ultimately this helps reduce the pressure on staff and hopefully improves the patient experience as well. And last but not least, to touch on research and pharmaceutical innovation, we see LLMs being used in some really interesting ways, from automating things like literature reviews to generating synthetic data for the purposes of testing and modeling new treatments. Now, like we said at the start, this list is by no means exhaustive. These are applications that are kind of already underway, and the pace of innovation means that we can expect many more to emerge over the coming months and years, certainly. So the next piece we wanted to show is a video that kind of demonstrates the art of the possible. The video is from it's a short video from a company called Hippocratic AI, who are based in the US, and this kind of shows how generative AI, powered and underpinned by large language models, can help bring care in a community setting. So do shout if you can't hear the sound, but I'm hoping it'll all be good.
Hi, Sarah. I'm Rachel, your AI care manager. How are you doing after your appendectomy?
I'm good. I'm glad to be home with my dog, Dennis.
It's great to hear that you're back home with Dennis. I noticed that Dr. Chang has prescribed you some antibiotics, specifically ciprofloxacin and metronidazole, due to your ruptured appendix. Were you able to get these medications?
I was. I did forget to mention to the doctor that I am allergic to penicillin. Is it still okay to take the medications?
Great question. The antibiotics you've been prescribed, ciprofloxacin and metronidazole, don't contain penicillin. So it's perfectly safe for you to take them. Can you begin taking them today?
Yeah, I certainly can. Do you have any tips for faster recovery?
Given that you have diabetes, keeping your blood sugar levels in check will be beneficial for your wound healing. Your hemoglobin A1C was at a healthy level of 5.5, but your glucometer readings from yesterday were a bit on the high side. So keep taking your metformin and try to steer clear of foods high in carbs. How does that sound to you?
I think I'll be able to avoid the carbs for the week. I need to go right now, but it was great talking to you.
I'm glad we had this talk. I'll pass along your progress to Dr. Chang.
Goodbye.
Goodbye.
So a fair amount going on in that video, but we've got, a patient, Sarah, who's speaking to Rachel, the AI care manager, on the screen. She's obviously recovering from her appendectomy. Sarah mentions she's back with her dog. Rachel, the AI care manager, recognizes this, provides a nice little bit of personalization. Rachel is also aware of the medications that have been provided to Sarah by her doctor and is able to action an allergy check for penicillin when Sarah mentions this. So it infers, it's reaching out to check some medication guidelines and then serving an answer. Rachel's also fetched data from Sarah's medical record, which is quite clear. So the whole encounter is very, contextually accurate, and is then able to pass progress along to the doctor, obviously inferring some integration with the EPR and the ability to understand what Sarah is saying. And the whole thing feels very much like a natural human-like conversation. Sarah doesn't have to say yes or no. She can respond how she normally would to a human, essentially, and the LLM will be able to translate that. And the key here with this whole solution is that the LLM is really the brain behind what makes all of this possible. So moving on from the art of the possible, we can look very quickly at what the future potentially holds. So a bit of a disclaimer, obviously this slide may not be in the right order of exactly how things are gonna develop, but these are certainly some of the key things that we wanted to highlight. So first off, and this is something that has very recently come about, particularly in the medical LLM world, is the ability for these to handle different types of data, so multimodal data ability. And that means that you can input different types of data into the large language model to get an output. So in the case of Google's MedGemma model that's recently been released, that can handle text and it can also handle images. So hypothetically, although we would not endorse this, you could potentially place an X-ray through, hypothetically of course, through MedGemma and ask it, can you see any broken bones and things like that. The next one we've got along the list is the rise of agentic AI, and this is very near future and is already here in some industries certainly. And this is where AI agents will execute tasks with a goal in mind. So they will aim to complete something, they will aim to reach a goal, and crucially they will work out the best way to reach that goal. So taking things a step further than your classic robotic process automation or RPA, which I'm sure many of us on the call are familiar with. So for instance, if a patient calls up to reschedule and there's a whole host of conditions around that rescheduling, which may trip up your sort of more classic RPA, an agentic AI agent will be able to access that reschedule successfully and will find the best way to do it. There's also integration to EPRs. So notably Oracle's next generation EPR, which they unveiled last year, will have AI built in across the entire system, allowing users to interact with it via speech or natural language and text, and return results. And this is all possible using LLM technology. As usual with technology, there will be hardware and software advancements that will continue. Things like being able to increase the efficiency of large language models, lowering the amount of compute required, increased accuracy. There may be a proliferation of open source models, which Ahmed was talking to earlier, which are obviously free to download. And with the rise of things like AI assisted coding, which is also done via LLMs, potentially someone who has very little or no experience with being able to code could create a whole application for a use case of their choosing, and this is of course like really exciting, and there's a huge potential for innovation. And lastly, although this is where I think our predictions start to get very stretched, is at some point in the future there will very likely be the creation of artificial general intelligence, or AGI, which is where artificial intelligence will start to surpass our human knowledge abilities. So what happens here is anyone's guess, but certainly it is looking likely. I think with all of this in mind, the use cases for LLMs, particularly in healthcare, will proliferate, they will increase, they will become more and more integrated. And obviously that brings us to safety, which is going to start to become increasingly important. So with this, I'll hand over to Paul.
Thanks very much, Gabriel. Just to check, everybody can hear me okay? All good? Okay, how are we doing for time, Maggie? All good. Okay. So We've had some of the foundations, albeit at a high level, because we were mindful of the audience. Didn't want to go too deep initially, but we will be having subsequent sessions. So we've talked about large language models, and now we would, I'd like to get to the product layer too. I know Gabriel touched on that in previous slides around use cases, but I've actually called out a couple of products here. Microsoft 365 Copilot is in moment, very talk of the town. I'm at NHS Confederation, so we had the Microsoft CEO yesterday interviewing somebody from Oxford Foundation Trust. They've got quite a large implementation there, and it is really driving productivity benefits of around 30,000 hours per month across that user base. So one thing to point out though is Microsoft 365 Copilot, and there was quite a discussion with NHS England safety team and myself in the early days about how we frame this. It's not for clinical use, or not for direct care, but of course it can still deliver, as it does in other industries, some significant benefits around productivity. That doesn't mean to say, though, of course, that there's still a lot of regulation that is included in that product, and that surrounds. I'll come to that in a later slide. But there are a number of controls that come with the product that are not specifically for tailored around clinical risk management, but around data protection and security, as you would expect. And again, I'll touch on that in a later slide. Now, Ambient Scribe, there are a number on the market, and that has caused an alarm from some of the pilots that have taken place from NHS England. There's been a couple of circulars that you may have seen that have been issued. One was issued earlier this week from the CCIO, and another one was issued back in April, which gave outlined some of the expectations that NHSE expect to see organisations that are procuring ambient scribe, ambient voice products in their organisations. And if you're not aware of that, we can put that on the BCS website. But essentially, this covers regulation, clinical risk management, the DCB standards, but formalised regulation as well, and also covers the distinction or creates more clarity around what types of devices fall within or highly likely to fall within that regulatory medical device regulatory landscape. So we would just touch on the next slide, Gabriel. So when it comes to intended use is really critical when it comes to defining whether it is a product is a medical device or not. But we'll come to that point in a second. I've taken these statements from sort of like a disclaimer flow, as it were, working from left to right. So we've got the foundation model disclaimer, so that's the OpenAI disclaimer, and you can see there that medical is, if it can affect materially an individual, then that is what we'd call off-label use, I guess. And then you've got the 365 Copilot transparency statement. Microsoft also have a terms of reference, but I put the transparency statement here, and it might be, I've seen some of the questions in the chat, and it might be quite useful to those individuals if they haven't seen that. But the transparency statement, it gives detail as to how the model has been designed, and the safeguards and how they mitigate against bias and that sort of thing. And one thing they also stress in here that I won't read it all out, you can see it for yourselves, but it's around the use within healthcare and the impact that could have, and it's not to be relied upon for those activities, which more and more now are coming under that regulatory microscope. And then on the right, we've got a client disclaimer. So that is just a snippet out of the acceptable use policy that NHSE has produced for Microsoft 365 Copilot, and uses that. So the biggest control is whether the user gets a license. Once they get the license, they can access, but they need to sign an acceptable use policy, which clearly outlines the limitations of the functionality and what it shouldn't be used for, as you can see there. And what I would recommend is that organizations that are piloting, if they haven't already done so, or organizations that are planning to take on Copilot, they then go to the next level, and then they integrate what you see here into their local policies around use, and obviously to train that out as they deem fit, and then the monitoring of that. Next slide. So, ChatGPT. So, I guess most people on this call, I would assume, have tried it. So, ChatGPT is obviously the product that is framed around the GPT model. It's the interface where you use the context window to put your queries, and as you can see here, it is being used in clinical practice. This was a survey that was undertaken last year. Probably doesn't surprise many on the call. So I'm quite an avid user of ChatGPT. I use a number of AI products. I class them as productivity tools, and but I don't use them in clinical care. I think in your own time to help with studies and that sort of thing. But actually, if you're using for direct clinical care, then there's a number of factors that come into play, not just around hallucinations, where it can give off incorrect information, even when you have that human in the loop layer. But there is also, you don't have the integration with the care record. There's not much visibility, if at all, around what your organization can monitor through prompt audits and that sort of thing, or what happens to that information. But it is being used, and I think this is there are various liabilities that would sit with those practitioners, and that would need to be seriously digested. But I think what this does shine a light on is that we need tools. So this is why there's an uptick in the market around ambient scribe, because once you see, and I had quite a nice demo yesterday in the up here in Confed and of one of the tools, and it is it's brilliant. It's the future. I'm in full support, but it's just, how do we do this in a safe, controlled manner? Because I don't think in the AI space there's much room for mistakes. I think certain newspapers would have a field day if things went wrong. And I think the general public, those on this call, might be pretty familiar about a lot with AI and its introduction in healthcare, but we are collectively have to be mindful how we position it, because it's there's a lot of eyes on this. In the middle there, I've just got a hallucination leaderboard, which I got off Techopedia. If you're interested, I think it's pretty bang up to date. And you can see the, well, actually, apologies, maybe if you zoom, you might be able to see it's a bit small, but the hallucination rates are low. I think you've got Google up there with their Gemini at the top, relatively low. I couldn't find any published, or there's no acceptable hallucination rate, understandably, at the moment. I haven't seen anything documented. I know I won't name the vendor that I was chatting with yesterday, but their hallucination rate, obviously they've got specialist tools to manage this, and it was lower than anything I see on here. But there's not a great deal of transparency around that at the moment, if I'm being honest. So that is just something to be mindful of, because I think when it comes to clinicians using these tools with confidence, then hallucinations is one of the hot topics, as it were. And also in that Techopedia article, I haven't put it in here, maybe for another session, but it was actually, as the models get more complex, or more as they get further designed to handle even larger data sets, and the actual hallucination rate is going up. You'd expect it to go down, but it can be quite significant. So that's a whole new presentation, I think, but maybe for another time. Next slide, please. So just back to intended use. MHRA provide guidance around this. Those on the call may well have seen it, and they've provided this guidance because the intended use is really critical. It guides your classification, and in doing so, that can send you down various conformity routes, whether it's self-certification, class 1, or whether you have to appoint an approved body, and then all of that work that stems, and costs that stems from that. And at the moment, we're in a bit of a situation with the EU regulation, the EU MDR, where ambient scribes are being classified as a 2A and above. And in the UK, the ambient scribes that I've seen on the PARD website are class 1, but we've got the regulation that will address that in due course. But I think it's fair to say if you have clinical decision support in there, then it's obviously class 2A and possibly B. So just another point to mention on this slide, there's intended use and there's claims, and you may think your product is not it doesn't fall within the MDR medical purpose definition, diagnosis, prevention, monitoring, treatment, alleviation of disease, but sometimes there's a bit of grey and it's not quite straightforward to determine, and organizations or suppliers can lean back on their chair perhaps and not go down the route. I know some that have done that, but then the claims can be quite adventurous. And it's just to say that MHRA do actively monitor websites, social media and so on. I've seen 2 in the last week where a certain person at MHRA have actually responded to a post, and if it went a bit quiet. But you really have to be careful about this point, but more so that you're not doing tons of regression work later on. Next slide, please. So this is the national guidance that came out. You're on mute, Maggie.
Just to say we've got 10 minutes left.
Right.
I think it's really important we get this right. And I am monitoring all your questions. I hope to paraphrase them before we close down. So Paul, if you could give us a couple of minutes. I think this is
I'll speed up.
Okay.
Okay. So very quickly, this is the NHSE guidance that came out in this isn't the circular. This is the guidance before that, and I've just broken it down in a table, and hopefully this slide's pretty self-explanatory. You've got the regulatory oversight at the bottom, so that increases as you move from low functioning to high functioning. That's how it was described in the document. I think that's a decent description. And the low functioning side, you've got simple transcription, and then the high functioning side, you've got that summarization. And of course, that summarization, when you are losing information that has been captured in that transcription, then potentially, critical aspects of that information may be missed. And then whether you have to copy and paste that or whether it flows into the record, again, different products are at different stages of that development life cycle. And then, of course, the downstream risks that come from that. Once that information, if it does seed itself into the record, then the downstream risks, because that check-in, that trust, it increases over time, and it only takes an occasion to let your guard down that you can have a serious incident. So I won't go through all of them in the interest of time. I think this might be one more slide very quickly on the governance and compliance. So this isn't exhaustive. It was just trying to pull out the domains, some of the domains within the DTAC. You've got your security, your adherence to the data security protection toolkit, and cyber essentials, essentials plus, and penetration testing to guard against prompt injections to the model. You've got your MHRA guidance and your clinical safety standards. And it's probably worth pointing out for those, I'm sure a number will be familiar on the call, but just in case, your DCB standard, your hazard log, does not meet the requirements of a 14971 assessment. Okay, so if you're not familiar with ISO 14971 and you're pushing medical device, it is different. You're focusing on hazardous situation, you're having to use different methodologies to tease out those hazards and show completeness, and it has to be robust, the traceability around that, and various other bits that I won't go into too much detail. And then you've got your DCB 0129, and the fact that you've got your ambient scribe pushing data or copying and pasting into that care record, and then it has to sit in the right place. Then that's where your DCB comes in. So you need that as well, because that is your interface layer into the EMR. Okay. Yeah, the good question there, 42,001. Absolutely. Last question, and just to address Tito's point, the AI Act is very clear about your high-risk products. Ambient scribe would meet that definition. Certainly, it goes off the MDR definition, and that is a AI management system to deliver on a lot of those requirements that are made in that AI Act, and also in the ISO 34971 in relation to risk assessment, specifically of medical device. Data protection impact assessment, and finally systems integration. So you've got all your interoperability stuff. And I'll stop because I could do another hour, and I better stop.
You could, thank you. Can we move on to the next screen, please? Thank you. So thank you for that. I will just try and summarize our questions. We have about 6 minutes left. We will, I promise, compile your questions, and they're very interesting and quite diverse, which is good. And that will help us shape our subsequent sessions. And I think there'll be at least another 2, if not many more. The event will be posted on the BCS site and indeed Eventbrite.